two medications have fundamentally changed the landscape of medical weight loss in the last several years: Semaglutide and Tirzepatide. You've heard their brand names: Ozempic, Wegovy, which are semaglutide, and Mounjaro and Zepbound, which are Tirzepatide. They're everywhere. Social media, podcasts, the morning news. Your neighbor's on one. Maybe your doctor has even mentioned one to you. And alongside the real results, because the results are real, there's also more misinformation, more hype, more bad advice, and more patient harm than almost anything I have seen in more than 20 years of practicing medical weight loss medicine. People are failing on these medications. People are regaining every single pound they lost, sometimes even more. People are dealing with side effects that should have or could have been prevented. And in too many cases, the reason is not the medication. The reason is that they never received proper guidance in the first place. Today, we're going to fix that. I'm Dr. Greg Oliver. This is Factor 3 of my 5-factor approach to permanent weight loss, metabolic enhancement. And in this video, we're going to go deep. The real data, the real expectations, the real myths, and I will address these myths on both sides because people are getting misled in both directions. And most importantly, what it actually takes to succeed long-term with these medications. Let's get into it now. Let's first look at how these medications actually work. To understand these medications, you need to understand one hormone, GLP-1, or glucagon-like peptide 1. It's produced in your gut when you eat. It signals your pancreas to release insulin. It slows stomach emptying, meaning food moves more slowly from your stomach into your intestines. And importantly, it signals your brain's hypothalamus that you are full. In patients with obesity and metabolic dysfunction, which causes overweight, this signaling system is impaired. The signal either does not fire strongly enough or the brain has become resistant to it. These GLP-1 receptor agonists or boosters are synthetic versions of this hormone. They're designed to bind the same receptors but with much longer half-life or duration. Instead of seconds, they work for days. The result? You feel fuller sooner. You feel full longer. Your appetite is genuinely reduced at the neurological level. This is not willpower. This is pharmacology addressing a hormonal deficit. Now, let's look at semaglutide, known as Ozempic or Wegovy. It has single receptor precision. Semaglutide is a once-weekly subcutaneous or under-the-skin injection that selectively targets the GLP-1 receptor. It was originally developed for type 2 diabetes management under the brand name Ozempic, and later at a higher dose specifically for chronic weight management as Wegovy. The STEP, S-T-E-P trial program, which is STEP stands for Semaglutide Treatment Effect in People with Obesity. This is the foundational evidence-based study. Step 1, which was published in the New England Journal of Medicine in 2021, showed that participants receiving 2.4 milligrams weekly of semaglutide achieved an average weight loss of 14.9% of their body weight over 68 weeks, compared to only 2.4% body weight loss in the placebo group. That's not a modest effect. That is a meaningful, clinically significant result. Roughly 1/3 of participants in the STEP trials lost more than 20% of their body weight. And that begins to approach the territory historically associated with bariatric surgery. Now, let's review Tirzepatide. It is a dual receptor binder. Tirzepatide represents the next evolution. It is a dual agonist or booster, meaning it targets two receptors at the same time. GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. GIP is another glucose-regulating hormone that plays a role in fat metabolism and insulin resistance and it, in combination with GLP-1, appears to produce an additive or synergistic effect. Its main trial was the SURMOUNT trial program, and it provided all the evidence. SURMOUNT-1, which was published in the New England Journal of Medicine in 2022, showed an average weight loss at the highest dose of 22.5% of body weight over 72 weeks. At the 15 milligram dose, the average was 20.9% loss, and 63% of participants achieved at least a 20% loss at the highest dose. So, to put that in perspective, a 250-pound patient losing 22.5% of their body weight has lost more than 56 pounds. This is not a diet result, this is a metabolic intervention result. Now, I want to move on to expectations from using these medications. One of the most damaging things that I see happening in regard to these medications, particularly through online prescribing platforms, is patients being started on these medications with completely unrealistic expectations about timeline and the trajectory of their weight loss. These medications do not produce dramatic weight loss in the first few weeks. The dose titration, which is slow or gentle adjustment of a medication or substance to produce the correct effect, this dose titration schedule is intentionally slow because purpose of titration is tolerability, not speed. With semaglutide, we typically start at 0.2 or 0.25 milligrams per week and increase gradually over several months to reach the therapeutic dose with a maximum dose of 2.4 or 2.5 milligrams per week. With tirzepatide, we begin with 2.5 milligrams weekly, and we may eventually go to a maximum dose of 15 milligrams weekly. Most patients see modest weight losses in the first 1 to 2 months. 4 to 8 pounds is pretty common. The weight loss curve steepens as the dose increases and the full appetite suppressing effect is established. The peak rate of loss typically occurs somewhere between months 3 and 6 for most patients. By week 68 in the semaglutide trials and week 72 in the tirzepatide trials, the plateau had largely been reached. The medications are not a permanent escalating weight loss machine. There is a ceiling, and it is different for every single patient. Each person varies with their response to these medications. The averages I just cited are exactly that. They're averages. There is a significant individual variability in response to these medications. Some patients are what we call super responders, losing 25, 30, or even 35% of their body weight. Other people plateau at 8 to 10% loss. Both are valid responses, but both are influenced by factors including their baseline metabolic rate, insulin sensitivity, hormonal status, gut microbiome composition, genetic receptor expression, dietary adherence, and physical activity. This is why I want my patients evaluated comprehensively before and during treatment, not simply given a prescription and told to inject it once a week. Your response to this medication tells us something important about your underlying metabolic physiology, and that information guides the rest of the treatment plan. So, what is the plateau and what does it mean? Every patient will reach a weight loss plateau, without exception. This question is when, at what weight? The plateau does not mean the medication has failed. It means you have reached a new metabolic set point. What happens at plateau is clinically important. This is typically when patients become very frustrated. This is also when bad advice from social media either tells them to stop the medication or try some new dramatic intervention. What the evidence actually supports at this stage is optimization of diet quality, structured resistance training to preserve lean muscle mass, evaluation of hormone status, and in some cases, reassessment of whether the current dose is still optimal. Patients who respond best long-term are those who use the reduced appetite the medication provides to actually build better dietary habits. The medication makes the change easier. The patient still has to make those changes on their own. Now, let's look at potential side effects of these medications. And this is an honest look at the side effects because you deserve that. These medications are not without adverse effects, and anyone who tells you otherwise is not being truthful. Well, the most common side effects are gastrointestinal, things like nausea, vomiting, diarrhea, constipation, acid reflux, and the feelings of fullness and bloating. In the clinical trials, somewhere between 40 and 60% of patients on active drug experience GI side effects at some point during treatment. The majority of these are mild to moderate, they're dose-related, and they're transient, meaning they go away. The key word is dose-related. Most GI side effects emerge during dose escalation and diminish once a patient stabilizes at a given dose. This is precisely why slow titration matters. Patients who are pushed too fast through the dosing schedule, which is common with online prescribing platforms optimized for selling more prescriptions rather than getting good outcomes, they experience higher rates of intolerance and discontinuation. There are also less common side effects such as injection site reactions. They're common but typically mild. Fatigue is reported by some patients, particularly in the early weeks. There's also a small group of patients who report hair loss, but this appears to be related to rapid caloric reduction rather than the medication itself, and it generally resolves over several months. Elevated heart rate was reported with semaglutide specifically and should be monitored in patients who have, say, a known cardiac arrhythmia or some type of heart or cardiovascular concern. Acute pancreatitis is rare, but it is a recognized risk. So, patients with a personal or family history of pancreatitis or active gallbladder disease require additional evaluation before initiating these medications. Gallstone formation is also a recognized complication of rapid weight loss by any mechanism or way and warrants monitoring also. Now, there is a black box warning, which is a serious warning, for thyroid C-cell cancer based on rodent studies. The clinical relevance in human remains uncertain. We've not seen that, but these medications are not to be used in patients who have a personal or a family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. You would most likely know if you have those. So, what about muscle loss with these medications? Here is the side effect that I believe is most underappreciated of public discussions on these medications, and the most dangerous in context of how they typically are being prescribed. These medications produce weight loss, but weight loss is not always the same as fat loss. Analysis of the STEP and the SURMOUNT studies show that a meaningful portion of the weight loss on these medications is lean mass, including our skeletal muscle. In STEP 1, approximately 39% of the total weight loss was lean tissue. In the tirzepatide trials, the ratio was somewhat better, about 25 to 30% lean mass loss, possibly reflecting the GIP receptor's role in muscle metabolism. However, the risk still remains. Now, why does this matter? Because muscle is metabolically active tissue. It is the primary driver of your resting metabolic rate. So losing muscle while losing weight sets you up for a metabolic slowdown, which in turn will make maintaining weight loss much more difficult, and which directly contributes to the regain pattern we see when these medications are discontinued. This muscle loss can be controlled or reduced and is not hard to do, but it does require intentional planning, adequate dietary protein, and a structured resistance training plan. These are not optional add-ons. They are essential components of a medically sound GLP-1 treatment program. And any program that does not address this is not giving you complete and quality care. Now, I'd like to address some specific myths and misconceptions that these medications come with. Much of it has to do with the problem with social media. And I want to spend some real time on this section because I believe the misinformation surrounding these medications is and can cause genuine patient harm and is coming from multiple directions. We are in a moment where social media platforms have become primary health information sources for millions of people, where online prescribing services with significant financial incentives to acquire and retain patients have filled a genuine access gap, but sometimes at the cost of individualized care, and where the volume and velocity of content about these medications certainly outpaces almost any ability to get a grasp on it or to correct it. Now, I'm not going to be real gentle about this because my patient's health is not a place for some kind of polite ambiguity. Let's talk about myth number 1. Ozempic is a miracle drug. Take it and the weight falls off. This narrative has driven enormous patient uptake and is doing some real damage. Yes, these medications are highly effective. I've already cited the data on that, but they are not passive interventions. The weight loss in clinical trials occurred in the context of caloric deficit, lifestyle counseling, and regular follow-up and treatment adjustment, not just taking shots. Patients who take these medications, who continue to eat ultra-processed, high-calorie diets, remain sedentary, and do not address the behavioral, hormonal, and psychological factors driving their obesity will not achieve the results they expect. And when they don't, many people just conclude the medication failed them. In reality, the medication was never given the conditions it needed to succeed. Myth number 2, you can stop when you reach your goal weight. Well, you can. But this is perhaps the most consequential myth, and it is one that has been perpetuated even by many clinical providers who are not well versed in the obesity medicine literature. The STEP 4 trial, which was published in JAMA in 2021, is very unambiguous on this point. Patients who had lost weight on semaglutide and then switched to placebo regained approximately 2/3 of their prior weight loss within the first year. Let me repeat that. 2/3 of the weight was regained in 1 year simply by stopping the medication. Why? Obesity is a chronic disease. The neurohormonal dysregulation that drives it does not resolve because you reach some goal weight. For the majority of patients, these medications will need to be continued long-term, similar to how we treat other chronic conditions. Stopping blood pressure medicine does not cure hypertension. Stopping these medications does not cure obesity, and it does not resolve weight issues. The patient who plans from the beginning to stop the medication at a goal weight is, in most cases, planning to regain the weight. Our job as doctors and clinicians is to have that conversation honestly and early. Myth number 3. The telehealth prescription is the same as a supervised medical care program. There are legitimate, high-quality telehealth providers and prescribers. I want to be precise here. The problem is not telehealth as a modality. The problem is business models that optimize the prescription volume rather than the patient outcomes. A GLP-1 prescription that arrives by mail with minimal intake evaluation, no baseline labs, no hormone assessment, no dietary guidance, no resistance training protocol, and a follow-up model that frankly consists of automated refill requests is not a weight loss program. It's a prescription delivery service, and the difference is in outcomes, and it is measurable and is significant. I see many patients who come to us after these programs. They've often lost some weight. They've also lost significant muscle mass. Their hormone status has never been evaluated. Their dietary patterns have changed. They haven't changed at all. And when the medications stop working as expected or when they cannot afford to continue, they have no tools and they have no plan. Myth number 4. These medications are too dangerous. The side effects aren't worth it. This is on the other side of the spectrum. There is a vocal contingent that treats these medications as categorically dangerous, primarily based on the black box warning and anecdotal side effects, which are reportedly amplified on social media. The evidence does not support categorical avoidance for appropriate patients. In the context of obesity, which in itself carries significant cardiovascular, metabolic, hepatic, orthopedic, oncologic, and mental health risk, these medications that produce 15 to 22% body weight reduction with a manageable side effect profile is, for most, appropriately selected patients a very favorable risk-benefit calculation. This means that reducing weight is much better for the person than not using these medications. The SELECT trial, which was published in 2023, showed a 20% reduction in cardiovascular events in patients with pre-existing heart or cardiovascular disease who were treated with semaglutide. And these are not trivial benefits. We want to reduce heart attack and stroke. Appropriate patient selection, proper baseline evaluation, slow titration, ongoing monitoring, and a framework within which these medications are safe and effective. Not everyone is an appropriate candidate to use these medications. And that's what clinical evaluation is for. Now, I'd like to move on to what actually creates long-term success. Using these medications is just one factor. Now, I named this particular segment of my program Factor 3, not Factor 1, not the only factor, Factor 3, because these medications, as powerful as they are, function best when combined with a comprehensive treatment plan. The medication creates an opportunity. What you do with that opportunity determines the long-term outcome. Let me walk you through what the evidence and our clinical experience over more than 2 decades show what actually creates lasting results. And that's what you want. First is the diet. It's about quality, not quantity. The appetite suppression produced by these medications reduces caloric intake, but it does not automatically improve the nutritional quality of what is consumed. Patients who continue to eat ultra-processed, nutrient-poor diets while on GLP-1 therapy will lose weight more slowly, they will plateau earlier, they'll experience more GI side effects, lose more lean tissue, and regain more rapidly when the medication is discontinued. The evidence consistently supports that a whole food, protein-enhanced dietary pattern, adequate protein is particularly non-negotiable. We typically target somewhere between 1 and 1.2 grams of protein per pound of target weight each day. So if your target weight is 200 pounds, you will need about 200 grams of protein daily while on your reduced calorie weight loss plan. Now, this is not a small amount of protein, and it requires intentional dietary planning. For patients with significant obesity, meeting protein targets while in the caloric deficit created by the medication requires some real focus and attention. We do not tell our patients just to eat less and move more. We give them specific, actionable nutritional guidance to their biology and their treatment protocol. Our second focus is on exercise and resistance training while on these medications. This is also non-negotiable. I want to be very direct here because this is probably the most consistently underemphasized component of GLP-1 therapy programs. If you are on semaglutide or tirzepatide and you are not doing some form of structured resistance training, you are allowing your body to consume your own muscle tissue as part of your weight loss program. And that is a problem that will compound over time. So, progressive resistance training 2 to 4 times weekly is the primary intervention that preserves muscle mass and body tone during this caloric deficit. Combined with adequate protein intake, it fundamentally changes the body's composition. And these medications will allow you to have stronger muscle, more toned body, and preserve that muscle. The metabolic benefits of this approach extend well beyond the scale. Lean muscle is insulin-sensitive tissue. Preserving and building muscle improves our insulin sensitivity. It reduces the metabolic adaptation that causes plateaus and creates a more favorable, long-term weight maintenance environment. Next, hormone evaluation and hormone optimization, if needed, is essential while on GLP-1 medication. This connects directly to Factor 4 of my program, which I've addressed in a dedicated video. But it does deserve mention here because it directly affects GLP-1 outcomes. Thyroid function, sex hormone status, adrenal function, and insulin resistance all influence metabolic rate, fat distribution, and response to GLP-1 medications. A patient with untreated hypothyroidism or low thyroid levels will plateau faster and lose less on semaglutide. A patient with significant testosterone deficiency will lose more muscle and less fat while on these plans. These are not minor variables. Every single patient in our program receives a comprehensive baseline lab panel that can identify these factors before we finalize the treatment plan. Optimizing hormonal status is not an optional enhancement to GLP-1 therapy. For many patients, it will be the difference between adequate response and exceptional response. Finally, we give behavioral and psychological support to our patients. The reduction in food preoccupation and appetite that these medications produce is a significant psychological relief for many people, particularly those with what researchers have termed food noise. That's that constant intrusive preoccupation with eating that characterizes many patients with obesity. But that relief can also mask patterns that need to be addressed and corrected. Emotional eating, disordered eating patterns, stress and cortisol-driven intake, sleep deprivation-related hunger issues, and food addiction behaviors can all persist in modified forms even with GLP-1 therapy. So what we find is patients who engage with behavioral support, whether formal therapy, structured coaching, or provider-guided behavioral planning, consistently show better long-term outcomes than those who rely on medication alone. To be the most successful and to get long-term results with these medications, long-term planning from day one is key. The conversation about long-term medication use needs to happen at the initiation of treatment and not when a patient reaches a plateau, and definitely not when they decide to discontinue the medication. Our model involves explicit discussion of the step 4 data with every patient before they start. They need to understand that these medications work by maintaining a biological effect that counteracts physiological drivers of weight regain. When that effect is removed, the medications are removed, those drivers reassert themselves. For some patients, this means long-term, potentially indefinite use of medication. For others, if we've successfully addressed the underlying metabolic, hormonal, and behavioral drivers, then a thoughtful, managed taper with close monitoring is a reasonable goal. But that's a clinical decision made with data, not just an assumption. Listen, I've been practicing medical weight loss since 2002, before GLP-1 medications became household names, before telehealth platforms even existed, before social media made every patient feel like they already know what they need before they even walk through the door of the doctor's office. And what I know from more than 2 decades in this arena is that weight loss medications are tools, powerful tools, increasingly sophisticated tools, but the outcome is still determined by the clinical relationship, the individualized evaluation, the ongoing monitoring, and the comprehensive support structure around the tools or around these medications. When a patient comes to us, they get a full metabolic workup, blood testing, they get a hormonal evaluation, they get a dietary assessment and a protein target, they get a resistance training plan, which is appropriate to their current fitness level and any physical limitations they may have. They get follow-up appointments where we're looking at their body composition, not just their weight. And they get honest conversations about the long-term commitment that successful weight management requires. I'm not saying that to be dismissive of access. Access to these medications matter, but access without clinical oversight is not complete care. And the patients who succeed long-term are the ones who received complete care. I'm going to finish up my talk now. Semaglutide and Tirzepatide are genuinely remarkable medications. The science is real. The results, when achieved in the right clinical context, are very real. But they're not magic. They are biology. And biology responds best to comprehensive, individualized management. If you're currently on one of these medications and do not have a clear protein target, do not have a resistance training plan or a hormonal evaluation, and a long-term medication strategy, I would encourage you to seek out a provider who can give you those things. You deserve more than just a prescription. If you're considering using these medications and you want to do this right from the beginning with the comprehensive blueprint that gives you the best chance of lasting results, make sure you find a provider who will be partner with you in your success. In my next video, I'm going to do a deep dive into key component of Factor 4, hormone optimization. Subscribe so you don't miss it. If you have questions, reach out. I'm here. I have been for more than 20 years, and I don't plan to go anywhere. This is Dr. Greg Oliver, and I'll see you next time.